organizing and scientific committee for OTOALEX for giving me a chance to share this scientific impact. Actually, our topic now is about the laboratory workup for dizziness. Our learning objectives for this lecture include first to understand the need for laboratory investigations for dizziness, and the second point is to elaborate on upcoming future laboratory tests for dizziness. Actually, the etiology of dizziness can be determined, as we all know, by history and physical examination in most of cases. But, however, for cases when the history and physical by themselves do not elucidate, because so a variety of sophisticated auditory and vestibular tests are available, supplemented by emerging imaging techniques to help diagnosis. So our question now, we are physicians, we look at the patient as a whole, not only one symptom. It is reasonable then to ask if there continues to be a role for a traditional laboratory test in diagnosis of patients presenting with complaining illness. Is there a place still or not? In some cases, the additional diagnostic tests should be ordered selectively depending on the type of business and suspected underlying etiologies. Unfortunately, the diagnostic testing is often ordered indiscriminately, meaning just ordered like that haphazardly without anything. And the frequency of ordering multiple expensive tests is increasing. We all see referrals coming from any clinic. The patient is doing a lot of investigation. Is it necessary or not? Particularly in the emergency department, because the patient complaining from business goes first to the ER, first, emergency department or emergency room. Diagnostic tests that may be helpful in patient in this equilibrium vary greatly depending on the identified neurological or mechanical deficits, but may include any neurological studies like electromyography, nerve conduction, cranial or spinal nerve, or other blood tests and other imaging. Diagnostic studies may be helpful, may be helpful in selected patients with pre-symptom and symptom not attributable to the medication for vasovagal attraction, include electromyography monitor, tilt-table tests, glucose tolerance, and other studies of autonomic and headache. Patients with non-ontologic dizziness and lightheadedness who demonstrate normal results from neurologic evaluation should be considered for what we call a head upright tilt-table test and normal, even with the normal in-office test. This is a test which is important. Many of physicians don't know about, but it is essentially sometimes for patients with orthostatic hypotension and antidepressants that in absence of any blood loss. The most important diagnostic test is the critical review of their medications, especially patients with antidepressant drugs. This is the tilt-table test in which we see that some physicians sometimes order, some otolaryngologists order this test that I have seen there. It is recommended to evaluate repeated unexplained episodes of lightheadedness, dizziness, or fainting. It can help determine if the cause is related to heart rate or blood pressure. This is found in the cardiology clinics most of the time, in the most clinics, not in cardiology. The nervous system, we know that it controls the heart rate and blood pressure, but it may suddenly lower heart rate and blood pressure for a short time when moving to an upright position during this test. As a result, less blood flows to the brain and possibly causing the fainting, which we see. A positive test where the blood pressure decreases, causing dizziness or fainting. Negative test, the heart rate increases only slightly, blood pressure doesn't drop significantly, and there is no signs of fainting. We know what the non-vestibular cause of dizziness. We all know any systemic lab tests to identify some cases, like directed tests such as the full blood picture, the serum glucose for hypoglycemia, the drug level, the drug, and the illicit or illegal drug screening, which is very important nowadays, especially in the youth population. Anemia, we all know it has a role in dizziness because RBCs are important. When the blood count is too low, it reduces oxygen carrying capacity and decreasing amount of oxygen supply to the rest of the body. Some serological tests are common. We need to do them, especially yes, they are rarely done, but we have to know about them because we cannot of them because they are rare. No, we have to think about them in some cases, some situations. Like the syphilis, because you know that syphilis goes in differential diagnosis with some other vestibular disorders. And there are only different types of serologic tests, antitrichoema and trichoema immunoassay, as we know. And the CDC recommends initial screening by antitrichoema test first. Another one is the Lyme disease, which is by a type of gram-negative spirochete and causing radiculopathy and CNS manifestations. And the CDC guidelines it recommends two test approaches, immunoassay and Western blot test. Some CNS causes of vertigo work out. We know that there are few laboratory studies which can diagnose the cause of vertigo. In the rare case of suspected Lyme pneumoborreliosis, the serology for the Lyme disease by the ELISA and Western blot and the lymphocyte antigen are indicated. Others see cerebrospinal fluid for the Lyme body test and polymerase chain reaction to evaluate the organism by DNA. Actually, Sohn et al. Found that the patients with acute onset vertigo indicated that the serum S100 binding protein beta and immune-specific immunase may aid in differentiation of central vertigo from peripheral. This is something new emerging. Especially in emergency setting, we need to differentiate peripheral from central. This is a good point to consider. And they found that the serum levels of these brain-specific proteins were significantly higher in patients with central vertigo. There have been research using blood tests have been done before by Parham 2016 work in blood tests to trace a protein called crestin, which is a specific protein found in the outer nerve cell. When they are become injured, it is found. From the level of this protein in one's blood, one can see if there is inner ear damage or not. Also, we work also another one protein to detect any vestibular anomalies. This protein is called OTOALEX 1. OTOALEX, it may be expressed only in the inner ear, and it is one of the building blocks of inner ear crystals, which we see in the cases of BPPV. He reported that these crystals eventually dissolved and the derivatives were released into the bloodstream. His study showed the presence of OTOALEX 1 in the blood of all subjects, but were much higher levels in those with BPPV, also patients older than 65 years of age. Although also Tabai et al. Reported that OTOALEX could be a convenient tool for assessing effectiveness for novel pharmaceutical treatment strategies. For example, the associations of BPP and osteopenia, osteoporosis, vitamin D, prostate in immunotherapeutic strategies, and OTOALEX in the circulation could be one measure to see their effectiveness. Also, the important role of structural proteins like OTOALEX 1, novel pharmaceuticals that stabilize structure of pneumonia could be explored and monitored, also to prevent the occurrence of BPPV attacks. Finally, a biomarker in circulation also could be a convenient tool to aid in diagnosis of tertiary presentations for BPPV. These cases include subjective cases of BPPV, because sometimes this is not evident, only the patient has complaints with subjective disease. Multi-canal presentation, bilateral case BPV, or when it is difficult to perform the diagnostic maneuver itself, but you cannot do it in some patients, like those kyphotic patients, frail or very fragile elderly, you cannot do them, you cannot perform the extant bite or any maneuver for them. Leah et al. 2022 examined the relationship of 25-hydroxyvitamin D serum levels at BPV instance and recurrence. He mentioned that many patients had insufficient vitamin D levels, and patients with recurrences with BPV had lower vitamin D levels than those without. Also, Zhang et al. 2022 found that serum estradiol, calcium, and 25-hydroxy levels of vitamin D of post-menopausal women with recurrent BPV were all positively correlated. And this figure shows a model linking the idiopathic benign paroxysmal positional vertigo. Here, when we see that increased vitamin D levels lead to increased parathyroid hormone, it acts on both organs, the inner ear and the whole. The inner ear leading to disruption of calcium absorption, resorption of calcium, ferritin, and fragmentation, and displacement of the fermented leading to idiopathic benign position. Here in the bone, there is increased level of receptor activator and decreased osteoprogesterone, increasing osteoclast and resorption of calcium, and decreased bone density leading to osteoporosis. So we know that critically ETAD 2022 revealed the increased high risk of recurrence in BPPV, because we know that BPPV is a recurrent disease. So he mentioned that there are comorbidities or factors acting on these recurrences. In patients with history of hypothyroidism, like Hashimoto's thyroiditis, because we see this a lot now. Now we see a lot of cases with hypothyroidism and autoimmune Hashimoto's thyroiditis is now started to be common. So they found association particularly strong with positive thyroid antibody dosage. The antibodies for thyroid levels were higher, and this is demonstrating association between autoimmunity and recurrence. Therefore, in complete evaluation of recurrent BPPV, they suggested investigating the thyroid dysfunction, but not only studying TSH 3T3 or 3T4, but also the autoantibody thyroid pattern. Now, all we know about COVID-19, and we see that we examined by PCR, Professor Dalia and Shams found that dizziness as an acute symptom was associated with COVID-19 in up to 14% of the patients, and BPV was the most common form. And this figure shows here the relation between the COVID and the inner ear. We see the three main entries into the inner ear causing the dizziness at the end, either CNS entry, hematogenous blood-brain barrier, vascular increase in the brain, another one associated contributing factors leading to dizziness, and last one, inner ear entry passing the hematological blood-brain barrier and through the cytokine storm and leading to dizziness at the end. ADLI 2022 concluded that dizziness should be considered a main symptom that deserves investigation and monitoring during COVID period, and 1/6 of these patients complained of new onset dizziness. Direct ischemic hypoxic and immune-mediated damage were the most likely mechanism underlying the vestibular system. Regarding the autoimmunity, we know that autoimmune inner ear disease, we also sometimes the patient complain of dizziness. When we examine patients, we find that the anti-nuclear antibody titer is very high, more than 180, and there is a reduction of T-naive lymphocytes. Also, the elevated levels of autoantibodies or circulating immune complexes antigen antibody reactions in the serum of Meniere, which can be candidates for diagnostic biomarkers for Meniere's disease. Also, in systemic sample immune disease, autoimmune like Bessel disease and COVID, we see that some peripheral leukocytes and moderate anemia are present in Bessel, and also antibodies for the nogal peptide were found in Kogal syndrome. Genetic studies, this is a very promising area now, and so many researchers are studying genetic to underlie the cause of disease. We see that they assume that it could be one of the causes of autoimmunity or increased immune reaction in Meniere, and the first gene locus associated with chronic Meniere has been identified using a genotype array. Here, the potential sites of inflammatory damage were the blood-brain barrier, the endolymphatic sac, spiral element, and reticular lamina, neurosensory epithelium. And the patients with this genotype have been shown to develop bilateral Meniere disease through the mediated neurotrophic factor KB inflammatory response. They call it sometimes familiar Meniere when they find it bilateral. Gautier et al. Uncovered sequence variants associated with type in a genome-wide associated meta-analysis study. He studied 48,000 cases in his meta-analysis study, and they uncovered association with six common sequence variants. And they found there has been association with BPV in those 6 common variants which he has studied. Finally, to sum up our lecture, we have some closing thoughts. We know that precise history is the first and essential step for diagnosis, and the systematic gathering of clinical information is particularly relevant, especially in the primary care setting, because we know that the dizziness patient goes first to the primary care setting or ER. The distribution of diagnosis in patients with vestibular dysfunction is different in primary care and in specialized neuroauthority clinics, therefore they have different needs. Each one is looking at the the patient from a different point. While the primary care professionals would benefit from training on maneuvers for repositioning, those in the specialized center need strategies for dealing with cases associated to other vestibular disease and refractory cases, because they're looking from another point in the sophisticated method. They need to do more research and look at the patient from a different point. Some future prospects regarding the investigations, we know that genetic research in vestibular disorder is still in its infancy, but it's going on. But it's promising, and it's very important. The development of cellular and animal models of vestibular disorders is needed to carry out functional validation of candidate genes obtained in human studies, and additional studies to determine the right diagnosis of most possible biomarkers for autological disease. This is a very promising area. Also, the vestibular disorders, we know that all of us that it is a complex disease. They are complex disorders, heterogeneous presentations, overlapping symptoms, making purely clinical diagnosis extremely challenging. Sometimes you cannot differentiate any clinical entity from the other. Deep phenotyping with a complete familial medical history combined with sequences will allow the identification of rare variants and genes related to familial vestibular disorders, allowing for more accurate classification of disease processes. In turn, furthering knowledge of genetic etiologies and pathophysiology of vestibular disorders will allow for the development and implementation of precision medicine. Precision medicine means genetic-based medicine, based on genetic study and individualized treatment, so vestibular disorder, including gene and stem cell therapies, because this is the future now. Thank you very much for your